I'm Dr. Carrie Jones. Today we're going to go over the top 5 reasons that I use the Dutch test. There are 5 broad categories when I evaluate the Dutch test and when I use it with patients, when I consult, when I talk to other practitioners about it, and we're going to break each one down so you can sort of understand the benefits and why I have loved it for so many years. So let's go ahead and dive in because there are a lot of tests on the market. There's saliva tests, right? There's blood tests, there's 24-hour urine test, of course, dried urine tests. So why Dutch? Why Dutch? And why do I go over the 5 things and give it a 5-star review? So number 1, it is research backed. Now, this is really important when you're looking at laboratories because if they can't back up what they claim, then how do you know that you can validate that for your patients and then come up with a good treatment plan or really truly make a diagnosis for them? And so it's important to know that Dutch is research backed, but I first want to dive into urine analysis over the years, just give you a little bit of history lesson, because I do hear in the field, well, there's no research on urine. There's no research on urine. It's a bogus test. When in fact, I hope everyone knows that urinary analysis is the original way that we used to make diagnoses. Now, of course, it's not a dried urine or a spot urine test, but I wanted to just walk you through how urine testing has been around for a long time. So the first recorded urine analysis through just visual only looking at urine was in 4000 BC, which is a long time ago. Indian physicians were credited with discovering diabetes via urine testing. They found that black ants were attracted to the sugar in urine, and if the ants were attracted to the urine, they suspected that the person had diabetes. Hippocrates figured out bubbles in urine correlated with kidney disease, while sediment occurred with fever. The higher the fever, the more sediment that showed up in the urine. So you can already see a trend. I mean, looking and evaluating urine has been around a long time. So I do find it really interesting when people say, oh, there's no research on urine. We know the 24-hour urine is quite popular. It's just a pain to collect. 24-hour urine collection started in the 11th century. In the 1600s, stone fragments and crystals could be identified, and in the 1800s, urine was first used to detect cancer cells. And of course, urinary pregnancy tests were developed in 1927. So the concept of using urine in medicine has been around for a very long time. So please be careful when you say, oh, there's no research around urine, when in fact, I hope you know, we've been using this to diagnose and address a whole number of conditions. Now, I do realize dry urine testing is newer, but it is researched. Specifically, the Dutch test is researched. In 2019, in BMC chemistry, it was completed collaboratively with the University of Southern California Reproductive Endocrine Clinical Laboratory, and showed the analysis of urine samples dried on filter paper provides results correlating with serum blood results. So a big question that Dutch got a lot was, I typically run estradiol and progesterone in serum. If I do a dried urine test, how can I be certain of the accuracy? So the result also showed a collection of 4 samples during the day. So the 4-spot method, which is what Dutch does, can be substituted for a 24-hour collection of the analysis of urine from dried samples is equivalent and is adequately stable as liquid urine samples. Again, 24-hour urine testing is quite popular, although a pain to collect, and it's been validated several times over. And so this study was showing that doing 4 spots through the day, the 4 samples throughout the day, is the equivalent as the 24-hour. And I'll show you a visual just of the estrogen and the progesterone. So this is throughout the menstrual cycle. They were testing women, and you can see serum progesterone range on the left, and then of course the urinary beta-pregnenolone on the right, and then on the bottom is serum estradiol and then urinary estradiol throughout the cycle of the women they were testing. And you can see that it correlates really pretty well. So if you do a serum progesterone on day 19, 20, or 21, you can expect it to be about the same as if you were to do a urinary test on the same day or in the same time frame. And the same goes for estradiol, which is really nice and convenient for when you're looking at the Dutch test to know that there is this research behind it. In 2020, in the Journal of Clinical and Translational Endocrinology, a study was done to determine the utility of dried urine sampling and obtaining measures of cortisol. So in the 2019, it was evaluated estradiol and progesterone. That was the most common question. And then next came cortisol. So the aim was to evaluate if a 4-spot urine collection is representative of a 24-hour urine collection, and if expected, the diurnal cortisol patterns can be observed in both urine and saliva. So 24-hour urine samples were often collected, obviously not just for steroid hormones such as estrogen and progesterone, but for cortisol as well, to get a total cortisol value throughout the day. And if you could do a 4-spot urine, then you could eliminate the hassle of collecting in the big orange jug on that 24-hour. And the same goes for the popularity of saliva testing with cortisol. Could we say that dried urine is representative of the results like a saliva test is throughout the day? And they showed it does. Dried urine is a viable alternative to liquid urine for the measurement of cortisol and cortisol metabolites. Additionally, if the 4 measures are added together, 4-spot urine collections can be representative of diurnal cortisol patterns commonly assessed using saliva, and 24-hour urine collections, of course, respectively. So the conclusion showed that if you are used to or have done in the past saliva collections for cortisol, that you could transition over to a dried urine spot test throughout the day, and you would get the diurnal cortisol pattern. And the same if you're used to doing 24-hour urine collection to see a total cortisol and cortisol metabolites, you would then be able to do that in a 4-spot urine as well for the Dutch test. In 2021, BMC Chemistry, reliability of a dried urine test for comprehensive assessment of urine hormones and metabolites. So next came the question of all the metabolites that Dutch was running. Would that be, again, to have research to back it up? The conclusion was yes, given the ease of sampling, handling the 4-spot urine assay would be useful for both clinical assessment of patients and for large epidemiologic studies. And they found that it was comparable. So the metabolites found in the 24-hour urine and metabolites found in the dried urine test were comparable, and which is wonderful because a lot of people, myself included, which is why I'm doing this, love the metabolite aspect of Dutch, love looking at the metabolite, the downstream, for those of you who are in metabolomics, the study of metabolomics, that the Dutch has this research to back it up. So as a practitioner, I appreciate that Dutch is involved with other research groups, labs, universities, and continues to publish. For example, a couple years ago, for those of you who love or use the Oura ring, when Oura was evaluating if it could be period predictive, they used the Dutch cycle mapping to see about temperature rises and then ovulation and progesterone rise, and they chose the Dutch test, the Dutch cycle mapping. And now, of course, the Oura ring has period prediction with its new Gen 3. There are other groups, there are other universities that are studying things such as breast cancer and evaluating estrogen metabolites and utilizing the Dutch test in its research study to evaluate those metabolites, because we know those phase 1 and phase 2 metabolites of estrogen can play a role in breast cancer. So I appreciate all this ongoing research. And in fact, if you want more information about this, right on the DutchTest.com website, there is a tab for research. And so you can download the paper and read it yourself. You can see what Dutch is involved in as it relates to research. So that is number 1. Number 2, now that you know it's researched, you're going to give it to a patient or maybe do it on yourself. And it's the ease of collection, because we know that if it's not easy for our patients or even ourselves, we're not going to do it. It's going to sit on the counter. We're going to be too afraid if it's a blood draw. It's going to be seen as a pain. We already have a lot of things on our plate. And so the ease of collection can make compliance, patient compliance, or even practitioner compliance, if you're doing it on yourself, that much easier. So if you are doing the Dutch Complete or any of the tests that require the urine collection, this is what it looks like. So it's done at home or wherever the patient is. I absolutely have had patients do this at work, or do this while traveling, or do this at, an Airbnb, and because it's so easy to collect. It is non-invasive, and then it's not a blood draw. So your patients who are afraid of blood draws, who pass out with blood draws, who've had a bad experience with blood draws, vein issues, they love this because all they have to do is urinate on the urine collection card, or they can urinate in a clean container. It doesn't have to be sterile, but it does have to be clean. And then they just dip the part of the card where the blue arrow is in, and then let it dry. Now, if we do the Dutch Plus or any of the tests that do involve the cortisol awakening response, then we switch to saliva, but we do swabs. We do not do any drooling or spitting into a tube. So this again is convenient at home or wherever the patient happens to be. And because we don't do spitting or drooling, they simply remove the swab, put it in their mouth, get it wet, collect the saliva, and return it back into the tube. Now, you may wonder why we don't do passive drooling or why we don't do spitting into that. And the reason is this. When you're looking to collect the cortisol awakening response, so when you're looking to collect that CAR, so cortisol awakening response is very specific. You test first thing in the morning on waking. So as soon as your eyes open up, you collect your first cotton swab, your saliva. And then you collect again 30 minutes later, and then again 30 minutes after that. So very rapid, waking 30, 30. Well, a lot of people struggle first thing in the morning to create this necessary saliva to fill up a tube in a rapid manner. You have less than 5 minutes to collect to get an accurate result. In fact, it could take, some people can take 10, 15, 20 minutes to fill up a tube, because if you've ever done it before, the bubbles don't count. So you have to drool into the tube or spit into the tube and then make sure you knock all the bubbles down. But if you're taking 10, 15, 20 minutes, you're already stretching out or missing the point of the CAR. You're trying to catch the rise in cortisol from point A to point B. It almost kind of almost is like the saying goes, as the crow flies. So you don't want it to be collecting all the cortisol in the tube over 20 minutes, wait 10 minutes, and then do it again. You want immediate collection and then immediate collection again 30 minutes later. All the research that is on the cortisol awakening response does use these swabs. They do not use passive spitting or drooling for this reason, because you're going to get an inaccurate result depending how long it takes a person to fill up the tube first thing in the morning. So Dutch follows suit, and they use the swabs, and wow, they are easy. Like I said, you just pop the top, stick the swab in the mouth, get it wet, and stick it back in the tube. Do it again 30 minutes later, do it again 30 minutes after that, specifically for the cortisol awakening result. I have talked to a lot of colleagues over the years. This is just one example of an actual conversation where they've had to fight with their patients around reminding them to get a blood draw, or fight with their patients, or having to collect 24-hour urine. The patient has forgotten. They did not collect the full 24 hours. They missed a couple of times because they were out running errands, or they were at work and were embarrassed, or they just plain forgot. They got up and went to the bathroom, forgetting they were collecting a 24-hour, and missed those collections. This is easier than, like I said in the slide prior, doing the saliva collection in, drooling or spitting into a tube. A lot of people don't like that. Maybe they have a condition where they have dry mouth and they can't create that much saliva, and using a cotton swab is much easier. And because urinating either in a clean cup or urinating on the filter paper is easier, and most people have probably done some sort of urine test in their life, whether they've had a bladder infection, urinary tract infection, a pregnancy test, an ovulation predictor kit, that a lot of people are really pretty familiar with being able to collect their urine, catch their urine, or just urinate on the card. So it is very straightforward, and it is very easy, and it's private. They don't have to leave their house. They don't have to make an appointment at a lab. They can just collect, let it dry, and mail it back. So patients really appreciate it, and therefore compliance goes up, which as a practitioner can be a really hard thing. That moves us on to number 3. So now you know the research behind the Dutch test. You know the ease of collection. You've now explained to your patient how easy it is to collect, and now you are going to get the results back. But first, you have to understand testing methodology. So when you run a lab, you as a practitioner really need to know what instruments are they using to get this result. Are they using something called immunoassay, or they're using something called mass spec? And you can see tandem mass spec and hormone measurement. There is a lot of research out there to say if you are measuring steroid hormones, estrogen, progesterone, testosterone, etc., you really should be using mass spec, because it's more specific as compared to immunoassay, which is not. And I'm going to show you an example, but I'm going to cover some other highlights too of the Dutch methodology. So like I said, mass spec, Dutch does use mass spec. They have a number of mass spec instruments in their lab. It's more specific and has a wider analytical range. And I'll show you what that means in a minute, because it doesn't make much sense now, but it will when I show you the visual of that. Dutch does have a specialty method to remove vaginal hormone contamination. I get this question a lot. Carrie, my patient is on vaginal DHEA. Carrie, my patient is on vaginal estriol or vaginal testosterone. What happens if it slides out and gets on the card? Is that going to artificially increase their DHA level, their estradiol level, their testosterone level? It will not. We do have a specialty method to help to remove that, so we can truly see what's endogenous as opposed to what slid out and landed itself on the card. And that's really pretty important, because not all labs have this ability, and contamination can be a real problem. We also adjust the data to account for creatinine's relationship with age, height, weight, sex, so it's more accurate to that person. And I love that Dutch does this, because creatinine plays a big role, especially as it relates to muscle mass. And I will show you, I'll give you an example in just a couple slides, so you know what that means. And to my knowledge, I actually don't know of a lab that does this. It doesn't mean there aren't labs out there that do, but it is very important to ask if you're doing hormones that you, in a urine test, that they do correct for creatinine. And by labs, I mean like labs that do spot urine and or a multi-spot urine. 24-hour urine labs do this. They do this, but the spot urine, other labs that do spot urine testing, I don't know that I've seen this other than Dutch. We also use the creatinine measurements in each of the 4 samples, and here's where it gets a little technical, using the volume inversely proportional to creatinine to get a weighted average instead of taking the sample volume from each sample. So in the report, your progesterone or your estrogen or your testosterone is a weighted average of all 4 samples. But we inversely, use the creatinine because it can also change, because like I said, things like hydration can affect your creatinine levels. So we correct for creatinine, and then we take the weighted average for each sample to give you in the result. So it is much more accurate to your patient, as opposed to just blindly adding all 4 samples together and saying, well, that's the total. We know being a urine test that creatinine plays a big role here. So let me go a little bit into mass spec. This is where I'm going to show you the visual on the instruments and how it's more specific and has a wider analytical range. So this is just a generic reference range. And so we're taking estradiol as an example. So the estradiol level on the left, that's the reference range, or the like the 0 all the way up. And so we're going to look at like a visual of what a Dutch test would look like. So if I was a premenopausal woman, so a cycling woman, then I would fit within that orange box. That would be the reference range that Dutch has identified as a female who should get her cycle. If she is postmenopausal, then she should be in the red box. Underneath it, that would be considered right at the bottom, which makes sense. Postmenopausal, she's not cycling, her hormones have dropped quite low. So a postmenopausal not on any kind of hormones would be below the premenopausal range. So this is what's conceptually called meaningful differentiation. We have a premenopausal range, we have a postmenopausal range. There should be a gap between the pre and postmenopausal range. There should not be any overlap. I think that makes sense to all of us. If I have a 28-year-old or if I have a 58-year-old, there should be, if they are in the normal range or the expected range, there should not be any confusion or overlap. Now, could a 28-year-old be in the menopausal range? Totally, absolutely. If she's amenorrhea, she may be right down there in that menopausal range. But if she's regularly cycling, everything is as expected, she should be not anywhere near the postmenopausal range, and she should be up in the premenopausal range. So anyone up there who's cycling expected should fit in that orange box. Any postmenopausal woman is an example. The star should be down there in the red box. There's a gap in the middle. So if I have a 28-year-old in the luteal phase and she's regular cycles, I'm like, yep, she is premenopausal. That's her range. 55-year-old with no period for a year, yep, she fits right there in the menopausal range. She's not in the premenopausal range. Now, this probably sounds basic and redundant. You're probably watching this going, obviously, like, of course, where else would they be? Well, it turns out if labs do not have the specificity to differentiate between the two pre and postmenopausal ranges, they overlap. So if you are using other labs, please be mindful of what their pre and postmenopausal ranges are, and do they overlap? There are other labs that absolutely do this, and I have used them. So it gets confusing when the postmenopausal range slides up into the premenopausal range, and then I'm trying to figure out, is she low premenopausal? Is she postmenopausal? What is she? Because the range just can't differentiate the two. So remember, going back to this visual, if she's in the premenopausal range on a Dutch test, she's clearly in the orange box. If she's postmenopausal, she's clearly in the red box. But now let's say we have the other lab has a different patient. My question is she in the premenopausal or menopausal range on this other lab? I don't know. I have to do more digging, right? I could take her age into consideration, her symptoms into consideration, family history, like when did the other females in her family go into menopause, things like that. But I really actually kind of like some differentiation here, so I know where she is. Now, if I were to have run the same patient on a Dutch test, then I'm pretty clear about where she fits. So if I draw a blue line all the way across, you can see she would be on a Dutch result, clearly at the low end of the premenopausal range, but she is not in the menopausal range. She is not in the menopausal range, but in the other lab, she is in the overlap between the pre and the post. So understanding this, if you are using other labs, please just take a peek at their reference ranges for things like estradiol and progesterone and see if they overlap. Can they have meaningful differentiation between these two stages of life, premenopause and postmenopause? Are there going to be times when she may be in that space in between? Of course, absolutely. Think perimenopause, think menopausal women who are on hormones. Absolutely. I'm not saying that. But if you are trying to differentiate somebody cycling from somebody menopausal and not cycling, they should not overlap. That time in life does not overlap cycling to no cycling. And that's what I'm trying to point out. Let's talk about vaginal contamination removal. So like I said, if someone is using vaginal hormone replacement therapy, has transdermal hormones on their fingers, they've rubbed in progesterone cream, they've rubbed in testosterone cream, and then they're like, oh gosh, I have to do my next, Dutch test, and they test the collection card, they're going to transfer the cream that is on their fingers onto the card. So how do you know the results reflect her system as opposed to contamination on collection? Like I said in the beginning, Dutch has a special process for this. So this ensures that patient results are not due to accidental contamination, which is a big sigh of relief because not all labs can do this. And sometimes when I know she's using vaginal hormone and then I see her results and I'm like, that does look like contamination. This is, and then I end up calling the lab. And so you can, I like that I can be rest assured with Dutch that they do have a special process for this to anticipate any kind of contamination, not endogenous. All right, let's move on to creatinine. Remember, creatinine, we are a urine test. Creatinine is definitely an important part of anything that has to do with urine and the kidneys. So it plays a role in the results. Creatinine is fickle. Creatinine is influenced by hydration, age, weight, height, and sex. So height and sex we can't really change, but hydration changes probably day to day, sometimes hour to hour. It changes as we get older. It changes as our weight fluctuates. And so this plays a big role in with the hormone results for the Dutch test. So Dutch adjusts results to reflect this information, so they're more accurate to that specific individual. Results you will see are listed as per creatinine. And as I said earlier, other spot or multi-spot urine tests do that. I don't know of another one that does, they might, but you want to look for that results listed as per creatinine. 24-hour due, they do make this correction, but you have to be careful with other spot or multi-spot tests and how they report it. So I want to give you that example that I said as it relates to muscle mass. So let's say a WNBA player and a figure skater have the same progesterone in a 24-hour period. So even though their height, their physique, their muscle mass are completely different, their ovaries can still produce the exact same amount of progesterone at a given moment. And that's what's going on. So their results on a 24-hour urine may be the exact same because 24-hour also evaluates creatinine. But on a spot urine or multi-spot, such as the Dutch test, it would become a progesterone per creatinine to correct for hydration, but it's slightly proportional to muscle mass. So the WNBA player who generally has more muscle mass would have results that are artificially lower by the increased creatinine if not corrected. So more muscle mass, more creatinine, and it could artificially make the progesterone look lower. Dutch corrects for this. So this is why on the Dutch requisition, they do ask for things like your age, your height, your weight, your sex, because they're going to evaluate based on what we know with creatinine. If the corrections are not done, the WNBA player would have a progesterone reported lower than they actually are endogenously. So with your patients, please make sure they do fill out that section on the requisition form around, of course, birthday, age, height, weight, and then sex. I know it can be uncomfortable. I do know that some patients do like to leave the weight part blank. Either they don't know or they don't want to write that down. And I completely can understand that and empathize with that. It will make the creatinine just a little bit, maybe not as accurate as you would like. So please advise them to include their weight on there, because as like in this example, when two females should have the same progesterone, because we correct for creatinine, I don't want the WNBA player to have what's an artificially lower looking progesterone, even slightly, compared to the figure skater. I want to be able to know that Dutch is correcting for that, so that I can address the WNBA player just like I would address the figure skater is around their progesterone results. So I know that's confusing because creatinine is kind of confusing. And if you're thinking that's kind of a mouthful and a lot to wrap my head around, just know that Dutch has you covered, and they are making this correction to be more specific to your patient. All right, number 4, the comprehensiveness of the results. So we've gone through the research, we've gone through the ease of collection. You can now feel confident with their methodologies, and now you're going to get the results. And this is what I absolutely love. This is probably the feedback that I get the most when I do consults with our colleagues, is about how visually it's really easy to read the test. So Dutch looks at a lot of markers. They look at 36 when we add them all up. So it's really the C in Dutch, which stands for comprehensive, right? Dry and urine test for comprehensive hormones, is quite accurate. So Dutch is a combination of the results written out and also results on a dial. So the dials are meant for those who really visually like to follow sort of the steroid pathway and understand if they're high or low, if they're in the luteal phase or the menopausal range for females, or age range for males, depending what the marker is. And they are read like a speedometer. So you will see that we have the green, first of all, they're dials, and then you see the two yellow or yellowish stars, and then the green. So in between the stars where the green is, that is the range for the luteal phase. The menopausal range, and I'm showing you just progesterone and estrogen as examples, the menopausal range is down in the purple. So again, there's that specificity where analytically we can tell the difference between the luteal phase and the menopausal range, and there is a gap. Can you fall in the gap in that gray area? Of course you can. But if somebody says, I am 60 years old and I haven't had a period in 12 years, she's probably solidly in the purple if she's not on hormones. You don't want any confusion that she would be somewhere up in the luteal range, because there's overlap in the reference range. So this is how you read a dial. They are read like speedometers, like they said. In between the stars, the luteal range, and then the purple for estrogen and progesterone shows you the menopausal range. We give the dial the same for every single patient, every single female, I should say. So the reason for this is because we want you to see as the practitioner what where she falls in relation to the luteal range and in relation to the menopausal range. So I get the feedback from colleagues, well, my patient's 60 and she hasn't had a period in 12 years. Why don't you just show me the menopausal? Because if maybe she's on hormones and didn't write it down, maybe she's going to go on hormones. Maybe you want to see where she is in relation to the luteal range. How far has she fallen? How into the menopausal range is she? So we give both ranges to everyone, all females, regardless of age, menstrual status, hormone status, so that you as the practitioner can see what's going on at a big picture. This is what the androgen, estrogen, and progesterone page looks like. This is a female report. I'm going to stick with the female report just for the sake of time. The male report does look very, very similar though. So you can see it's a lot of dials and a lot of arrows, and it kind of looks overwhelming at first, but then you just have to start at the top and follow the arrows down, and you're looking at a steroid pathway, which is what makes it so nice. So in the upper right-hand corner are the progesterone metabolites. And so with the Dutch test, they do not do progesterone directly. They look at the alpha and the beta pregnadiol, which are the two progesterone main metabolites. Beta, the beta pregnadiol is the most abundant metabolite, progesterone metabolite, that humans have, male or female. But it's the alpha pregnadiol, that gets a lot of press because it's the alpha that goes on to become allo, A-L-L-O, crosses the blood-brain barrier and binds to GABA receptors. So it's the alpha metabolite that is calming, relaxing, soothing, and supports those who can't sleep very well. So we give both metabolites because it's important to know both, because somebody could be beta dominant, somebody could be alpha dominant. And if you're working with somebody who is struggling with anxiety or calmness or insomnia, you can look at that alpha and see if their alpha is low or lower, especially compared to the beta. So that's why Dutch gives both. Below that, we have the estrogens. Estrogens are E1 estrone, E2 estradiol, and E3 estriol. So in this case, you can see, I'll go up one, progesterone, read it like a dial. This female is below the star, but just at the upper end of the menopausal range. So she's in that gray area for sure. So she is not ovulated and she is not making progesterone. Below that though, she is making plenty of estrogen. Her estrogen is in the red and above the luteal range star. So for all of them, she's very estrogen dominant on this day of her cycle. Then below that, we look at her phase 1 metabolism. Phase 1 metabolism is it uses hydroxylation. OH is hydroxy. So this is where you get the famous 2-hydroxy, 4-hydroxy, and 16-hydroxy. When it comes to, you can see how she's going through detoxification. If this were a male report, it would be the same. We report phase 1 and phase 2 for males as well. There is a pie chart on the right. The pie chart is the percentage of those metabolites coming through at that time. So in the dial are the actual numbers, and the pie chart on the right lets you know of the amount coming through the urine, what percent is 16, what percent is 4, and what percent is 2. Now remember, keep in mind, the 16 is considered estrogenic. It can bind, they can all bind to estrogen receptors, but 16 can bind somewhat stronger. And then we have the 4-hydroxy, the 4-OH. That one is the one that's associated with the most carcinogenic risk. That is the one that is associated with DNA adducts, and therefore DNA damage. And then the 2-hydroxy is just less carcinogenic. It is not no carcinogenic. It still can form adducts, but in the DNA. They are more stable though, so it is generally considered less carcinogenic. And the 2 pathway is of course the pathway that we generally are encouraging. Once you go through phase 1 hydroxylation, we look at methylation as it goes for estrogen metabolism. And this is where they go through COMT, catechol O-methyltransferase. So the Dutch test is not a genetic test. They do not actually evaluate the CYPs, CYP 1A1, 1A2, 1B1, or 3A4, or COMT. but the enzymes are listed there, the SNPs are listed there. So if you do genetic testing, you can pair them together and get an idea of what's happening in real time, which is showing you on the Dutch test, and what genetically they have on their report. So for phase 2, we want to get from hydroxylation over to methylation or methoxy, and you'll see the 2-methoxy and the methylation activity is listed there. So we gauge the activity and give you kind of a range to show you of, yes, they seem to be methylating their estrogen well, or no, they seem to not be methylating their estrogen well, and then you can address it. Androgens look like this. So DHEAS and bioavailable testosterone are in the upper left-hand corner, and then the androgen metabolites and the 5-alpha reductase gauge. The 5-alpha reductase gauge includes things like 5-alpha DHT, 5-alpha androstenediol, because that alpha pathway is the one that's associated with things like PCOS and hirsutism and cystic acne on the jawline and mood issues such as anger and irritation. And in males, we have male pattern baldness, perhaps prostate issues. And so this pathway is really important to pay attention to when your patients have this. And I appreciate being able to look at this really quickly visually and know in this example, this person is an alpha person. So if they're complaining of those symptoms, now I know why. And if I was going to consider giving them androgens, maybe it's DHEA or testosterone, I could look at this and know they are going to be at a higher risk for side effects of that supplementation. Then we move to the cortisol page, which is known as page 5 on a Dutch Complete or a Dutch Plus, and we look at melatonin, which I always appreciate. Melatonin is waking melatonin, which sounds totally counterintuitive, but it's actually all the melatonin that your patient has been making and then putting in the bladder through the night. They wake up first thing in the morning, urinate it out. So it's for waking melatonin, but it's really through the night melatonin. So I can see if my patient, male or female, is making melatonin through the night in appropriate numbers. Total DHEA production is here because, again, a lot of your DHEA, DHEAS is made, of course, in the adrenal glands. This is the adrenal page. Metabolized cortisol, then I can get a sense of that enzyme 11-beta HSD. So 11-beta HSD1 activates cortisol. 11-beta HSD2 deactivates into cortisone. So I can tell if they're an activator or a deactivator when it comes to their cortisol and cortisone levels. Then the Dutch Complete diurnal graph. So the patient on a Dutch Complete is in the red, and ideally they're in the gray shaded area, but you can see here their free cortisone on the left and free cortisol on the right is quite low. So this person does not have a lot of free hormone, and they're probably very tired, and they're dragging along the bottom of the gray shaded area. And I like to see the cortisone because I like to see that 11-beta HSD marker, because again, if they have low cortisol but more cortisone because they're deactivating, then it's not a production issue, it's a deactivation issue. In this case, though, everybody's low, and so it's a different story. This is not a deactivation issue. So I get more information about my patients as it relates to cortisol, which I really, really like, so I can really hone in and help to improve them faster. If you do a Dutch Plus, then it switches to blue. So the patient result is in blue, and they want to be in the gray shaded area. And it looks a little bit the same as the Dutch. I'll show you this to this. This is the plus, but remember with the Dutch Plus, because the cortisol awakening response is very rapid. First of all, this is the saliva free cortisol. This is the urinary free cortisol. So they are two different types of collection. The reason this is saliva, again, is that you have to collect immediately on waking, 30 minutes later, and 30 minutes after that. So it's a very quick microscopic look at their cortisol in the morning so you can see what's going on. And I really, really like this, especially for my patients who say, in the morning, I wake with anxiety, I wake with pain, I wake stressed out, I cannot wake up, I need lots of caffeine, and I hit the snooze button a lot of times. I wake with autoimmune symptoms, whatever that is. That's when I really appreciate the cortisol awakening response. Page 6. Page 6 are the organic acids. So MMA, which is methylmalonate for B12. On the Dutch test, some companies use ic acid, methylmalonic acid. Dutch uses the 8, so methylmalonate. It's the same thing, just different titling. And I really appreciate looking at MMA because this is this marker is tied to adenosine B12. As your MMA goes up, it's likely your adenosine B12 has gone down. This is not methyl B12, this is adenosine B12, which has to do with your Krebs cycle. Your methyl B12 has to do with your methylation cycle. So two different cycles, very important, two different cycles. So if you see MMA going up, don't think methyl, think adenosine. You can also sub for hydroxo. Then we have xanthuronate and kynurenate. Again, kynuric acid, xanthuric acid, same thing in other testing. And these are commonly, if these go up, it typically means that the person needs B6. And of course, the active form of B6 is P5P. Then we have pyroglutamate, which is associated with glutathione issues and need for glutathione. Either they can't make it, they don't have the precursors for it, they are using it up, something's going on, there's some sort of infection, they need some antioxidants, and so pyroglutamate's a really potent one. Then there are the two neurotransmitter metabolites, HVA and VMA. So HVA for the dopamine metabolite, VMA for norepinephrine and epinephrine metabolite. These are not direct markers of, meaning that they're not one-to-one dopamine, one-to-one norepinephrine and epinephrine. HVA does not mean that's exactly what your dopamine is doing in your body. You still need to break down dopamine into HVA. It's a multi-step process. It does involve SNPs, such as COMT and MAO, but these markers could give you indication as like if they're really tired and their cortisol is low and these markers are low, that they are probably struggling in those neurotransmitter production as well. If they're very stressed out, anxiety, hypervigilant, not sleeping, these markers are high, probably safe to say that these neurotransmitters are high in their body as well. Melatonin we already talked about, and last but not least is the ever important oxidative stress marker called 8-OHDG, 8-hydroxy-2-deoxyguanosine. It is a marker of DNA damage. When the DNA is getting damaged, then it releases 8-OHDG only in the urine, and the higher this is, the more concerning for your DNA. Now, worst case scenario, of course, it could be cancer. But it can also be other things like chronic insomnia. I've seen it with severe depression. I've seen it with mold exposure, heavy metal exposure, very ill people because their DNA is just really getting attacked. And so don't always think cancer, but if it's been a while since they've had any kind of workup and you see a high 8-OHDG, the first thing I think of is like, wow, we need to do some digging. I need to figure out why this is in this case on the high end of range or even out of range. And then number 5, to round us out, of course, of why I love the Dutch test, our clinical support in all of our education. Dutch has a lot of it. Dutch has a lot of clinical support and education. So all the videos and information online are free. There are monthly webinars that are completely available in the library that you can go back and learn about a number of topics. There's a whole onboarding process for new providers who sign up so that you don't feel lost, so that you can have your handhold, that you have an onboarding person to answer all of your questions, because I understand that any new lab can be overwhelming, and certainly Dutch is a comprehensive test, and to have somebody who can hold your hand through the process is really helpful. Then once you get your results, there's a whole team of clinicians who do clinical consults through phone or Zoom, over email, Monday through Friday. And if I do say so myself, since all of them are my good friends, they are absolutely top notch. And so I just really appreciate, and our colleagues do too, that when they're stumped on a report or going over a report for a first time, just to have somebody with a lot of experience say, here's how you read page 1, here's how you read page 2, all the way to page 6. And really just help walk you through it. And of course, the entire Dutch staff and all departments who routinely answer questions, resolve issues, they're so helpful and so amazing. Of course, I'm completely biased, but the feedback that they get is right in alignment. And I just love that about all the people at Dutch. And so those are my top 5 reasons that I absolutely love the Dutch test. I hope that was informative. So as you're going through, you have a better idea about Dutch itself, the methodology, and then looking over the report and how helpful and how comprehensive it is. So again, I am Dr. Carrie Jones, and I really appreciate you listening.